High-frequency jet ventilation delivers rapid bursts of pressurized gas through a specialized adapter attached to the endotracheal tube. Each pulse lasts only a few milliseconds and produces a narrow, high-velocity column of flow that travels deep into the airways. Unlike oscillatory ventilation, exhalation during jet ventilation is passive, driven by the natural recoil of the lung and chest wall. The conventional ventilator connected in tandem provides baseline flow for humidification and establishes the positive end expiratory pressure that maintains lung volume between jet pulses. The system functions through two coordinated circuits: the jet ventilator controlling rate, inspiratory time, and driving pressure, and the conventional ventilator maintaining oxygenation and mean pressure. The jet handles ventilation, determining how carbon dioxide is cleared, while the background ventilator sustains oxygenation by setting the baseline lung volume. This design allows precise control of ventilation at lower mean airway pressures, which is particularly useful in fragile or air leak-prone lungs. Because the inspiratory pulses are brief and focused, pressure dissipates rapidly once each pulse ends. The mean pressure within the lung therefore remains lower than in oscillatory ventilation, reducing the risk of further alveolar rupture or hemodynamic compromise. Gas exchange occurs through a combination of laminar flow, coaxial streaming, and penduloft movement between lung regions with different time constants. The result is efficient carbon dioxide removal with minimal additional volume load on the lung. Jet ventilation is especially effective for conditions with heterogeneous compliance or existing air leak, where maintaining low mean pressure and precise control of tidal volume minimizes further injury. Understanding how the jet and conventional ventilator interact forms the foundation for managing and troubleshooting this dual system effectively. High-frequency jet ventilation relies on the physics of high-velocity flow to deliver small, rapidly pulsed volumes of gas into the lung. Each jet pulse lasts about 0.02 of a second and produces a narrow column of laminar flow through the center of the endotracheal tube. This column carries fresh gas to the distal airways, while exhaled gas moves outward along the periphery of the lumen. The result is a coaxial flow pattern in which inspiration and expiration occur simultaneously in separate layers, providing continuous gas exchange with minimal volume displacement. Because the inspiratory phase is so brief, airway pressures return quickly toward the baseline set by the conventional ventilator, which acts as a continuous positive airway pressure source. Exhalation occurs passively through lung recoil. This allows mean airway pressure to remain low, even while driving pressure during each jet pulse may be high. The rapid cycling creates efficient carbon dioxide elimination through convection and enhanced diffusion while limiting barotrauma. The distance that each jet pulse travels and the degree of gas mixing depend on airway resistance, lung compliance, and pulse energy. In compliant lungs, gas penetration is deep and uniform. In stiff or fluid-filled lungs, penetration shortens, and a larger driving pressure or slower rate may be required to maintain clearance. The jet's coaxial flow pattern bypasses much of the anatomic dead space, which explains why ventilation remains effective despite extremely small tidal volumes. The combination of rapid flow, passive exhalation, and low mean pressure gives jet ventilation its defining physiologic advantage: precise control of ventilation with reduced risk of overdistension. The system's efficiency and safety, however, depend entirely on maintaining a patent endotracheal tube and an intact tandem circuit so that each high-velocity pulse can transmit its energy predictably to the lung. The jet ventilator determines carbon dioxide clearance through adjustment of rate, driving pressure, and inspiratory time. Each of these variables influences the amount of gas delivered during each pulse and the total ventilation achieved per minute. Understanding how they interact allows precise control of ventilation while maintaining lung protection. Rate, typically between 360 and 420 breaths per minute, determines how often high-velocity pulses are delivered. Lower rates lengthen expiratory time and increase tidal displacement with each pulse, improving carbon dioxide removal but raising the risk of air trapping. Higher rates shorten each cycle, producing smaller tidal volumes that stabilize the lung but may allow carbon dioxide to rise. Rate should be adjusted in small increments while observing the response in blood gases and chest motion. Driving pressure, or jet PIP, is the most direct control of ventilation. Increasing driving pressure increases pulse energy, tidal volume, and carbon dioxide elimination. Excessive driving pressure, however, raises mean airway pressure and risks barotrauma. Adjustments are typically made in 2 to 3 centimeter increments while monitoring carbon dioxide and chest expansion. The goal is to maintain gentle, visible chest vibration extending to the mid-thigh without exaggerated movement. Inspiratory time is fixed at about 0.02 of a second in most neonatal systems, producing an inspiratory to expiratory ratio near 1 to 3. This timing minimizes gas trapping and allows adequate recoil for passive exhalation. In cases of persistent carbon dioxide retention, despite high driving pressure, inspiratory time can be lengthened slightly to increase volume delivery, provided exhalation remains complete. Together, rate, driving pressure, and inspiratory time form the ventilatory control system of the jet. Their careful balance determines effective carbon dioxide clearance while preserving the low mean pressure that protects fragile neonatal lungs. The conventional ventilator operates in tandem with the jet system to maintain oxygenation and baseline lung volume. It provides continuous bias flow for humidification, establishes positive end expiratory pressure, and may deliver occasional sigh or backup breaths. This background ventilator creates the mean airway pressure on which jet pulses are superimposed, forming the foundation of gas exchange during high-frequency jet ventilation. PEEP defines the baseline lung volume. Typical settings range from 10 to 14 centimeters of water, adjusted to maintain oxygen saturation with the lowest possible inspired oxygen concentration. Too little PEEP promotes de-recruitment and shunting, while excessive PEEP causes overdistension and air trapping. Changes should be gradual, followed by evaluation of chest expansion and oxygen requirement. Rate and sigh breaths on the conventional ventilator are used sparingly, usually between 0 and 5 breaths per minute. These breaths help maintain alveolar recruitment, but should not interfere with the jet's rapid cycling. When sighs are used, their inspiratory pressure is set about 10 centimeters above PEEP, with an inspiratory time of 3 to 0.5 of a second to allow complete filling of slow lung units. Inspired oxygen is adjusted independently on the conventional ventilator. Oxygenation reflects the combined effect of FiO2 and PEEP, not jet driving pressure. Bias flow of 10 to 15 liters per minute keeps the circuit flushed and humidified, ensuring stable mean pressure and consistent gas delivery. The conventional ventilator's settings must complement those of the jet. Together, they create a stable baseline pressure, maintain functional residual capacity, and support oxygen diffusion without imposing large pressure swings. Coordination of both systems allows the jet ventilator to focus on ventilation, while the conventional ventilator preserves lung volume and oxygenation efficiency. Side breaths are low-frequency conventional inflations added to the jet system to maintain alveolar stability and prevent gradual collapse. Because the jet delivers extremely small tidal volumes, the lung can slowly de-recruit if no larger breaths are given. Sigh breaths re-expand partially collapsed units and restore uniform lung volume without interrupting high-frequency ventilation. The primary goal of adding sighs is to preserve functional residual capacity when oxygen requirements remain high or imaging shows underinflation. Sighs are most useful in diffuse disease such as respiratory distress syndrome, pulmonary edema, or evolving bronchopulmonary dysplasia, where compliance is uneven and some regions close between jet pulses. After suctioning, handling, or brief disconnection, sighs can also help reestablish baseline lung volume. Sigh breaths are introduced cautiously and discontinued once oxygen improves and lung inflation is stable. In the presence of an air leak or pulmonary interstitial emphysema, they should be avoided because large inflations may enlarge existing leaks. Hemodynamic instability is another reason to defer sighs, as transient rises in intrathoracic pressure can worsen venous return. The decision to add sighs depends on both oxygen trend and radiographic expansion. They serve as a temporary recruitment aid rather than a permanent component of jet ventilation. Once alveolar stability is restored and oxygen need falls, sighs can be removed to allow pure high-frequency support with minimal pressure fluctuation. When sigh breaths are added to jet ventilation, the conventional ventilator is used to generate them while the jet continues to provide rapid pulses for ventilation. Settings are kept gentle and infrequent to avoid disrupting the jet's low mean pressure advantage. The rate is set between 2 and 6 breaths per minute, giving sufficient time between sighs for passive exhalation and jet function. Peak inspiratory pressure is usually 8 to 10 centimeters of water above baseline PEEP to open alveoli without overdistension. PEEP remains at 10 to 14 centimeters of water to sustain recruitment between sighs. Inspiratory time of 3 to 5 tenths of a second allows uniform gas distribution to slow-filling regions. Bias flow around 10 to 15 liters per minute maintains humidification and flushes exhaled gas from the circuit. The inspired oxygen is shared between both systems and adjusted for target saturation. Assessment focuses on the effectiveness and tolerance of sighs rather than numeric settings. Improvement in oxygen with reduced requirement indicates successful recruitment. Falling blood pressure, asymmetric expansion, or hyperinflation on imaging signals, excessive pressure, and the need to reduce sigh intensity or rate. Persistent oxygen need despite sighs suggests unrecruited regions that require higher baseline PEEP or reevaluation of overall lung strategy. Sigh breaths are temporary and should be removed once the lung is stable. Prolonged use increases mean airway pressure and can negate the protective advantage of the jet. Their role is to assist recovery from partial derecruitment or handling events and then return control of ventilation and oxygenation to the coordinated jet conventional system. Servo pressure provides continuous feedback on how efficiently the jet ventilator delivers each pulse. It represents the gas flow energy the system must generate to achieve the set peak inspiratory pressure. Because the ventilator automatically adjusts flow to maintain that target, changes in servo pressure directly mirror changes in lung mechanics or circuit conditions. When compliance improves and the lung becomes easier to ventilate, less flow is required to reach the same pressure, and the displayed servo pressure rises. This counterintuitive pattern, rising values with improving compliance, reflects that the system no longer needs to compensate for stiffness or resistance. A falling servo pressure, in contrast, indicates increasing resistance or loss of effective volume. Causes include derecruitment, accumulating secretions, endotracheal tube obstruction, or pneumothorax compressing lung tissue. Tracking servo pressure over time provides a dynamic picture of the lung's response to therapy. Consistent upward trends with stable gas exchange suggest recovery and potential readiness to wean driving pressure or rate. Sudden decreases without other changes should prompt immediate evaluation of airway patency and circuit integrity. Comparing servo behavior with blood gases prevents overreaction to a single reading, as stable oxygen and carbon dioxide levels confirm adequate function even when numeric servo values fluctuate slightly. Servo pressure trending is therefore both a safety monitor and a compliance gauge. It helps distinguish physiologic improvement from mechanical problems and allows fine adjustment of jet settings to match the evolving condition of the neonatal lung. Observation remains the most immediate and reliable indicator of jet ventilator performance. The expected finding is fine, symmetric chest vibration extending to the lower abdomen with each burst of the jet. This subtle motion confirms that high-velocity pulses are reaching the distal airways. Diminished or absent vibration indicates airway obstruction, circuit leak, or disconnection. Asymmetric motion suggests main stem intubation or unilateral disease, limiting transmission of jet flow. Stable heart rate, color, and perfusion reflect adequate oxygenation and cardiovascular tolerance. Hypotension developing after an increase in PEEP or driving pressure signals overdistension and should prompt a small pressure reduction. The audible rhythm of the jet also provides information. The sound should remain soft and even. Abrupt changes in pitch or volume may indicate leaks, condensation, or shifts in servo pressure. When gas exchange worsens, the pattern of change points toward the cause. Rising carbon dioxide with stable servo pressure implies that frequency is too high or amplitude too low. Rising carbon dioxide with falling servo pressure suggests obstruction, derecruitment, or tension pneumothorax. Increasing oxygen need usually indicates loss of lung volume from inadequate PEEP, circuit leak, or airway collapse. Hyperexpansion on imaging or decreasing blood pressure reflects excessive mean pressure or driving pressure. Effective troubleshooting follows a consistent sequence. Verify chest movement, inspect the circuit for leaks or water, confirm airway patency, and check servo pressure trends. Most issues can be identified and corrected without large setting changes. Careful observation and small, measured adjustments restore balance between oxygenation and ventilation while maintaining the lung protective advantage of high-frequency jet ventilation. The jet ventilator incorporates safety systems designed to protect the patient and alert the clinician when effective ventilation is interrupted. Understanding the meaning of the ready condition and the loss of PIP alarm prevents unnecessary interventions and ensures that support is restored quickly when a problem occurs. The ready condition indicates that the system is fully calibrated, servo limits are established, and alarms are functional. When the ready light is illuminated, the jet is operating in its normal, protected mode. If the display shows not ready, the ventilator is calibrating or recovering from a power or flow interruption. During this period, alarms are temporarily disabled, and the system should not be used for patient ventilation until it returns to ready. Starting ventilation in the not ready state bypasses safety features and risks unmonitored changes in pressure delivery. The loss of PIP alarm activates when the ventilator cannot achieve the set peak inspiratory pressure. The most common causes are circuit disconnection, suctioning, endotracheal tube obstruction, or condensation that limits flow. The correct response is to look first at the patient. Verify chest motion and reconnect or clear the circuit if needed. The Enter key should never be pressed during a loss of PIP alarm because this command shuts off jet flow, leaving the patient without ventilation. The alarm resets automatically once normal function returns. Frequent or unresolved. Loss of PIP alarms signal either a mechanical problem or worsening airway resistance. Persistent alarms despite circuit inspection warrant evaluation for obstruction or air leak. Recognizing and responding appropriately to these alerts ensures continuous ventilation and prevents inadvertent interruption of life support. Weaning from high-frequency jet ventilation focuses on reducing support while maintaining stable lung volume and gas exchange. Because the jet delivers rapid, small tidal pulses superimposed on a constant baseline pressure, the process must be gradual to prevent derecruitment or air trapping. The sequence begins with reduction of inspired oxygen to less than or equal to 30% while maintaining target saturations. Once oxygenation is stable, positive end expiratory pressure is decreased in 1 centimeter increments, observing for changes in oxygen and chest expansion. After PEEP reaches 8 to 10 centimeters of water and lung inflation remains uniform, driving pressure is reduced in small steps to keep carbon dioxide between 45 and 55 millimeters of mercury. Rate is lowered only after driving pressure is near its minimum, since rapid changes in rate can disrupt gas clearance and stability. Throughout this process, servo pressure trends help identify improvement in compliance. A gradual rise in servo pressure at stable gases reflects an easier-to-ventilate lung and readiness to wean. Conversely, a drop in servo pressure with worsening gases suggests airway obstruction, fluid accumulation, or derecruitment, requiring reassessment of PEEP or suctioning. Most infants transition back to conventional ventilation before extubation. The background ventilator's PEEP and oxygen settings are maintained, while the jet rate and driving pressure are tapered. Once FiO2 is low, PEEP near baseline, and spontaneous effort returns, the jet is discontinued and conventional support continues for final weaning. Direct extubation is rarely necessary, but can be considered in larger or more mature infants on minimal settings with stable oxygen and carbon dioxide. Weaning from the jet requires patience and close monitoring of both gas exchange and mechanical feedback. Small, deliberate changes maintain recruitment and allow the lung to recover without reintroducing pressure-related injury. Exhalation mechanics distinguish high-frequency, oscillatory ventilation from high-frequency jet ventilation and largely define how each mode behaves under changing lung conditions. In HFOV, exhalation is active. The oscillator piston or diaphragm reverses direction with equal force during expiration, pulling gas out of the airways as effectively as it pushes it in. This bidirectional control maintains alveolar stability, prevents gas trapping, and allows the mean airway pressure to remain constant across the cycle. Active exhalation is the reason HFOV can operate safely at higher mean pressures without causing hyperinflation, because the system clears gas efficiently even when the lung is stiff or poorly compliant. In HFJV, exhalation is passive. After each jet pulse, the lung empties through its own elastic recoil and airway resistance. The ventilator does not actively withdraw gas. As a result, the time allowed for expiration becomes critical. If the jet rate is too fast or the expiratory time too short, residual gas accumulates, leading to air trapping and potential hyperinflation. Conversely, sufficient recoil time allows complete exhalation and keeps mean pressure low, which benefits infants with air leak or poor venous return. Understanding these differences guides how each mode is applied. In HFOV, adjustments in frequency and amplitude modify both phases symmetrically, maintaining constant mean pressure. In HFJV, rate and inspiratory time must be balanced carefully to ensure full recoil and prevent dynamic hyperinflation. Recognizing whether exhalation is active or passive explains why HFOV favors homogeneous lung disease with stable volume, while HFJV is better suited for heterogeneous compliance and air leak-prone conditions. High-frequency oscillatory and jet ventilation share the goal of minimizing lung injury through small tidal volumes and stable mean airway pressure, but their mechanics and clinical roles differ. HFOV uses a single system to generate oscillations around a constant baseline. Both inspiration and expiration are active, producing a smooth sinusoidal pressure waveform. Mean pressure remains steady, promoting uniform alveolar inflation and consistent oxygenation. HFOV is most effective in diffuse disease where lung units respond similarly to pressure, and recruitment can be maintained evenly across the parenchyma. HFJV delivers high-velocity pulses through a jet adapter, while the conventional ventilator provides baseline pressure and oxygenation. Inspiration is active, but exhalation depends on lung recoil, producing an asymmetric pressure waveform with a lower mean pressure. This configuration allows precise control of ventilation while maintaining gentle support for air leak or heterogeneous disease. The ability to separate oxygenation and ventilation control gives HFJV a particular advantage when carbon dioxide management is difficult or air trapping is a concern. The key distinctions therefore lie in pressure behavior and flow mechanics. HFOV maintains constant lung volume and distributes pressure uniformly, but can affect venous return if mean pressure is excessive. HFJV minimizes mean pressure and supports uneven lungs, but depends on passive exhalation and careful timing to avoid gas trapping. Both modes are lung protective when applied correctly, and the choice between them should match the disease pattern. HFOV for uniform collapse, requiring recruitment and stability, HFJV for uneven compliance, leaks, or need for lower mean pressure. High-frequency ventilation alters the normal interaction between ventilation and circulation. The sustained mean airway pressure that keeps alveoli open also increases intrathoracic pressure, which can reduce venous return and cardiac output if set above the optimal level. This effect is more pronounced in hypovolemic or preterm infants with limited myocardial reserve. Maintaining adequate intravascular volume and careful adjustment of mean pressure prevent this secondary cardiovascular compromise. The distribution of pulmonary blood flow changes with lung volume. In underinflated lungs, alveolar collapse and hypoxia cause regional vasoconstriction, redirecting blood towards still aerated areas and increasing shunt. Overdistension has the opposite effect, compressing capillaries and elevating pulmonary vascular resistance. Both extremes impair gas exchange efficiency. Stabilizing the lung near its functional residual capacity minimizes these variations, resulting in more uniform perfusion and improved ventilation-perfusion matching. In infants with persistent pulmonary hypertension, maintaining steady oxygenation and avoiding abrupt swings in intrathoracic pressure reduces pulmonary vascular reactivity. A stable mean airway pressure enhances the effect of pulmonary vasodilators by distributing them evenly across recruited alveoli. Excess pressure, however, can worsen right ventricular afterload and impede pulmonary blood flow, emphasizing the need for fine pressure control rather than aggressive recruitment. Systemic perfusion should be monitored continuously through blood pressure, urine output, and lactate trends. Any decline following pressure adjustment should be treated first with volume replacement or minor pressure reduction before altering ventilator amplitude or frequency. The objective is to sustain both pulmonary and systemic circulation while maintaining the lung in its most efficient, stable configuration for gas exchange. Persistent pulmonary hypertension of the newborn results from sustained elevation of pulmonary vascular resistance and right-to-left shunting across fetal circulatory pathways. High-frequency ventilation and inhaled nitric oxide complement each other by stabilizing lung inflation, improving oxygen transfer, and promoting selective pulmonary vasodilation. HFV maintains uniform alveolar expansion and prevents the pressure and oxygen swings that aggravate pulmonary vasoconstriction. When mean airway pressure is adjusted to achieve stable lung volume without over-distension, perfusion distributes more evenly across alveoli. This improves oxygen delivery to the pulmonary arterioles, the trigger required for nitric oxide to exert its local relaxing effect. The combination of optimal lung recruitment and nitric oxide therapy enhances matching between ventilation and perfusion, reducing shunt and improving systemic oxygenation. If lung inflation is inadequate, nitric oxide reaches only a fraction of the pulmonary surface, producing little improvement in oxygenation. Excess mean pressure, however, compresses capillaries and worsens right ventricular afterload. The ideal strategy is therefore to use HFV to establish a stable, moderately inflated lung, then titrate nitric oxide to achieve selective vasodilation of well-ventilated regions. The response is monitored through oxygen saturation and pre- and post-ductal gradients. A consistent rise in systemic oxygen confirms improved pulmonary blood flow and reduced shunting. When combined appropriately, high-frequency ventilation provides the mechanical stability that allows inhaled nitric oxide to function as intended, producing effective, regionally targeted vasodilation while avoiding additional lung injury or circulatory compromise. Selecting between high-frequency oscillatory ventilation and high-frequency jet ventilation depends on matching the ventilator's mechanics to the dominant lung pathophysiology. Both modes provide lung protection through small tidal volumes and stable mean airway pressure, but their control logic and ideal applications differ. HFOV is preferred when disease is diffuse, and the primary issue is alveolar collapse or surfactant deficiency. The ability to hold a steady mean pressure with active inspiration and expiration allows uniform recruitment and consistent oxygenation. HFOV works best for homogeneous lungs where overdistension and leak risk are low, such as respiratory distress syndrome or diffuse atelectasis. It also stabilizes oxygenation in infants with pulmonary hypertension once the lung is recruited and nitric oxide therapy is underway. HFJV is better suited for heterogeneous or leak-prone lungs. Its brief, high-velocity pulses ventilate efficiently at low mean pressure, reducing the risk of further leak in pulmonary interstitial emphysema, meconium aspiration, or air-trapping syndromes. Passive exhalation and adjustable baseline pressure from the conventional ventilator allow independent control of oxygenation and carbon dioxide clearance. HFJV is also useful when precise carbon dioxide management is required despite fragile compliance, as in pulmonary hypoplasia or post-operative diaphragmatic repair. The decision matrix can therefore be summarized by physiologic goals. Choose HFOV when oxygenation and uniform lung recruitment are the priorities. Choose HFJV when ventilation control, air leak management, or pressure limitation are paramount. Neither mode is universally superior. Success depends on selecting the system whose flow and pressure characteristics best fit the infant's disease pattern and maintaining it within a protective, stable lung volume range. Effective management of high-frequency ventilation depends on recognizing early signs of malfunction or physiologic imbalance and correcting them methodically. Most problems arise from circuit issues, loss of lung volume, or inappropriate adjustments made in isolation. Consistent assessment of chest motion, gas exchange, and ventilator readings prevents escalation of injury or instability. Loss of chest vibration is one of the most urgent cues. It usually indicates obstruction, disconnection, or significant derecruitment. Immediate inspection of the endotracheal tube, circuit, and humidifier is required before altering settings. If obstruction or water accumulation is not the cause, evaluate for pneumothorax or main stem intubation. Rising carbon dioxide can result from inadequate amplitude or rate, excessive frequency, or new compliance loss. Adjust amplitude or driving pressure first, then consider reducing frequency slightly if clearance remains poor. When carbon dioxide rises with falling amplitude or servo pressure, obstruction or atelectasis should be suspected rather than mechanical failure. Sudden oxygen deterioration most often reflects derecruitment from circuit break or suctioning. Increase mean airway pressure by 1 to 2 centimeters of water and confirm symmetric chest motion. If oxygen remains low despite recruitment, review hemodynamics and perfusion before further pressure escalation to avoid overdistension. Common pitfalls include chasing displayed values, such as delta pressure or servo pressure, without confirming their clinical context, and making simultaneous adjustments to multiple parameters, which obscures cause and effect. Other errors include prolonged disconnections, excessive suctioning, or humidifier malfunction, leading to airway drying and secretion plugging. A systematic approach: assess the patient first, verify the circuit, then adjust one variable at a time, ensures stability, and maintains the lung protective intent of high-frequency ventilation. Clinical studies comparing high-frequency ventilation with conventional mechanical ventilation show that outcomes depend more on timing and technique than on the mode itself. When high-frequency ventilation is applied early and used to maintain a stable, recruited lung, it reduces exposure to high tidal volumes and may lower the incidence of air leak syndromes and chronic lung disease. When used late as rescue therapy after injury is established, benefits are less pronounced because the structural damage and inflammation are already present. Randomized trials in preterm infants with respiratory distress syndrome demonstrate that both HFOV and HFJV can achieve equivalent or slightly better oxygenation at lower mean airway pressures. Meta-analyses indicate that early use of HFOV modestly decreases the risk of bronchopulmonary dysplasia, but may increase transient air leak if mean pressure is not carefully titrated. HFJV has shown particular benefit in pulmonary interstitial emphysema and in heterogeneous lung disease, where conventional ventilation fails to control carbon dioxide without worsening leak. Long-term follow-up studies reveal no consistent difference in survival or neurodevelopmental outcomes between infants managed with high-frequency versus conventional ventilation, provided lung protective strategies are applied in both groups. The key determinant of success remains avoidance of large pressure swings, maintenance of adequate lung volume, and precise control of oxygen exposure. The collective evidence therefore supports high-frequency ventilation as an effective tool within a comprehensive lung protection framework. Its advantages are realized when it is introduced before severe injury, managed with attention to physiologic feedback, and integrated with strategies that stabilize hemodynamics and minimize oxidative stress. High-frequency ventilation provides lung protection by maintaining stable lung volume and reducing the repetitive opening and closing that cause injury. Both oscillatory and jet systems achieve this goal through different mechanisms that suit distinct disease patterns. HFOV drives gas movement with an active piston that controls both inspiration and expiration. This bidirectional flow stabilizes pressure and keeps alveoli uniformly inflated, making HFOV most effective in diffuse or homogeneous disease, such as respiratory distress syndrome. HFJV delivers rapid, high-velocity pulses with passive recoil during exhalation, producing efficient carbon dioxide clearance at lower mean pressure. It is favored for conditions with uneven compliance or air leak, such as meconium aspiration or pulmonary interstitial emphysema. Regardless of the mode, maintaining recruitment is essential. Lung volume should be established gradually and preserved through consistent mean airway pressure and prompt re-recruitment after suctioning or disconnection. Rapid weaning or abrupt pressure changes risk collapse and oxygen instability. Adequate humidification and sedation prevent resistance and promote synchrony with the ventilator. Pairing high-frequency ventilation with surfactant or nitric oxide therapy, when indicated, improves oxygen delivery and vascular stability. The central objective remains the same across all high-frequency modes: protect both lung structure and systemic perfusion. By keeping the lung open, minimizing pressure swings, and coordinating respiratory and circulatory management, high-frequency ventilation supports effective gas exchange while preventing the progression of ventilator-induced injury.